Good morning, everyone. My name is Dr. Robert Groysman with covidinstitute.org, and today I'm doing a podcast with Alice for the European Facebook groups. Alice, please take it away.
Hi, Dr. Groysman. Thank you so much for giving time. Really appreciate it.
My pleasure.
Thank you. Looking forward to hearing what you have to say as we go through the questions that I've put. Just to explain, everyone, I'm afraid you're very lucky, actually. You can't see me because my camera isn't streaming very well. So we're just going to focus on Dr. Groysman, who is far more interesting than I am. So to give you a bit of a background as to how this all came about, I have a 9-year-old daughter who has long COVID and ME as a joint diagnosis. She first contracted COVID in 2020 and had what we see, but it subsequently looks like it was long COVID then. And then she had another infection and a vaccination very close together, and that just completely decimated her function. Bedbound for best part of a year, lots of complex problems. So I've been following doctors for periods of time to try and, look deeper into who I expect and want to listen to further, who I trust. There's a whole minefield out there for parents or for sufferers who just don't know where to focus their finances or their attention to try and get treatment. So we're focusing on Europe. I also thought it'd be really interesting to have this, discussion about how it's treated and looked at in America, because globally it's very interesting how different countries respond to the issue of long COVID. So here are some facts and figures for you, because I like those. But as of 2024, the estimates available on the World Health Organization website that 36 million people across the WHO region may have experienced long COVID over the first 3 years of the pandemic. And that equates to approximately 1 in 30 Europeans. They're very wishy-washy words, but that would be because it's very hard to get, finite data when there were so many people that haven't been diagnosed formally, even now. So it's still a very significant number and shows what a huge problem long COVID is on a global scale, as focusing in on Europe today. So a 2023 study showed that 94% of European countries have COVID-19 as an occupational disease under certain circumstances. Sorry, not COVID-19, long COVID.
I know what you meant.
Yeah, thank you. So the interesting part of that is that actually they all have differing criteria for how to recognize it. So that I've spoken to a lot of people from different countries over the last few years, and it is unbelievable how many countries just do not do anything to support people with long COVID. It's shocking. I feel quite lucky that I'm based in Germany, because they did have long COVID clinics straight away, sort of 2 years after the pandemic. Say they cropped up on a pretty rapid scale. They do have pediatric long COVID clinics, but unfortunately, there's a very long waiting list, so there's not enough. But I've spoken to people in Switzerland who say that they don't even acknowledge long COVID. France, children are being put into psychiatrics, or parents are being, investigated for. It's those are the extreme ends, but it's happening. So, Dr. Groysman, I was very keen to find out for you some specifics about, the basics. What is actually happening in the body during long COVID? Just to give us your
Sure.
advice.
I'd be happy to start with that, but I first want to mention a few things about what you've said. I do think that pretty much the entire world is very much behind in acknowledging and addressing long COVID. Some countries like Germany have um, done a fairly good job at least addressing one of the main mechanisms, which is endothelial dysfunction microclots, which we'll get into later.
Mm.
I do think that there's more acknowledgement now in the USA of long COVID. A lot of money has been put forth for the Recover program from the federal government. However, I think a lot of the money has been wasted and not properly allocated to looking at treatment options. A lot of it has been wasted on observational studies, which unfortunately, we kind of know what long COVID is, and we don't need surveys to find out who has it and who doesn't. We need treatment options. We need treatment modalities tested and determined to see if something can really work for long COVID. What I have seen mostly in Europe and on the other side of the pond is that uh, there are clinics that really only focus on one mechanism. Um, in Europe, really, the big thing is the help apheresis, which is in Germany. There's also, I guess, one clinic in Cyprus, in Greece, but Germany kind of takes the forefront for this. And there's one doctor there that really focuses on this. So you asked me what I think is going on with long COVID. Well, after doing extensive research for the last 5 years, I've distilled the mechanisms that are involved. And the reason that I focus on the mechanisms rather than on the symptoms is because each and every symptom that occurs in long COVID, and there's over 200 of them, over
Mm.
200 symptoms. Now, that doesn't mean that every single person is going to have 200 plus symptoms, but they're going to have different constellation of symptoms from those 200 plus. But each one of those symptoms can be caused by each of the six mechanisms. So it's
Okay.
important to determine which mechanism is causing which symptoms, because if you're just treating the symptom, you're really not treating anything. I hope that makes sense because you don't know what mechanism to treat if you don't know what the cause is. We're talking about the root causes here of each of the symptoms.
Yeah,
So,
and actually, it's going to be very helpful for you to hear you list them out because, from a parent's perspective, there's been a very confusing journey to this point, trying to identify what I should focus on and what care
sure.
and treatment.
And
Yeah.
most important thing I can tell parents and really everyone is don't focus on the symptoms. The point is to figure out what mechanisms are involved. And each person is going to
Mm.
have different combinations of these mechanisms. But what I can tell you with a fairly high degree of certainty is that every single person with long COVID has more than one mechanism involved. And that's because long COVID is a multi-mechanism disease. Okay? So,
Yeah.
focusing on one mechanism is rarely going to be successful for the majority of people. You really kind of need to figure out all the mechanisms involved and treat all the mechanisms. Now, having said that, it's not always easy to determine all the mechanisms involved. So, you look for the most obvious ones that are present and you treat
Mm.
those, and then you see what else is left over. What other mechanisms are still going on? It's kind of like peeling an onion. So you may
Yeah.
see the outer cover, but until you peel that off, you won't see the lower layers. So here I'll even do better than tell you the mechanisms. I'll show them to you.
Okay. Brilliant.
If I can figure out how to do that. Give me 1 second here.
I refer to it as whack a mole.
Here we go. So this is I just made this up quickly this morning to show.
Okay.
Yeah, I went and put this together in about 15 minutes. But this is kind of to show the primary mechanisms involved. Now, of course, before here in this area here will be COVID, the virus itself, and the spike protein, and they work distinctly differently from each other, even though they're both part of each other. And we can even put
Okay.
COVID vaccine injury in here as far as the spike protein part. So the
Yeah.
first one is dysautonomia. This is the most commonly involved mechanism in long COVID. A large percentage of people with long COVID will have one or more forms of dysautonomia, and it's split off into three subgroups, which is fight or flight, POTS, which is postural orthostatic tachycardia syndrome. That's really kind of the mechanism where you stand and you have a fast heart rate, tachycardia, and you get dizzy.
Yeah.
Okay, that's really fundamentally what POTS is. And vagus nerve dysfunction, which affects your gut, like gastroparesis, which affects your vocal cords and swallowing. So you may have a hoarse voice, you may have trouble swallowing, things like that. And of course, heart rate. This also affects heart rate. Second mechanism, again, most common second mechanism is mitochondrial dysfunction. And COVID directly damages mitochondria in certain cells. And the top two subcategories on the mitochondria will be post-exertional malaise, which is
Yeah.
where doing a minor effort, either mental or physical activity, will cause a significant fatigue and just feeling not well for a day or even a week or sometimes even a month after some activity, and the
Yeah.
neuroinflammation. Okay, those are the top two under that. Then we have the endothelial dysfunction microclots, which is the third most common mechanism involved in long COVID. And this is the one that Germany addresses with the HELP apheresis. Next, we have
Mm.
the gut dysbiosis. And this also has two subcategories, which is the leaky gut. And the main issue there is the LPS, lipopolysaccharide, which leaks from the gut lumen into the bloodstream, causing problems. And you have the low butyrate producing species. Um, then you have the MCAS, histamine, and histamine intolerance. They're technically two separate categories, even though they result in high histamine regardless. And
Yeah.
lastly, is we have hormone imbalance. And for that, we're talking about cortisol, we're talking about testosterone, we're talking about progesterone, estrogen, and thyroid hormone. Those are the main hormones involved there. This is probably the least involved out of the six. But nevertheless, each of these six can contribute to all the symptoms that you have in long COVID. Like I said, not every single person is going to have all six. Some people have three,
Yeah.
some people have two, some people have four. But there are a few that have all six, which is fun to treat. But identification is the first step.
I have to say this is like a very joyous diagram for me because this completely lays out exactly what to know, basically, in a very easy, digestible format.
So
So,
I can even show you even kind of more kind of easier to understand. So if we look at um, again mechanism contribution, this is kind of basically how it falls out. Okay, two long COVID symptoms. So if we look at symptoms only, how many symptoms come from dysautonomia? Percentage, roughly. Number of symptoms, how many symptoms come from MCAS, from hormone imbalance, endothelial, mitochondrial, and gut dysbiosis. So this is basically a number of symptoms only. So you can kind of see dysautonomia is always going to be at the top. Here's another
yeah.
way of looking at it. This will be the last one, sorry. And basically showing why and how I came to the conclusion that all of these mechanisms are involved. Here are the studies listed showing, and again, it's more than one per mechanism, and approximate prevalence, that is, how many people have this mechanism involved in their long COVID. As you can see, dysautonomia and mitochondrial dysfunction typically are at the top. And this is a graphical um, way of seeing the breakdown of contribution of each mechanism in long COVID. This is just statistically. I
Yeah.
like graphs. But anyway, let me remove this for you. And
No, that is helpful. It's already made, it's put in with my personal situation exactly what is the issue actually.
sure, and I just wanted to show you guys that I'm not just drawing these. I'm not just drawing these out of my imagination. I'm following the evidence and everything. There's real data here showing all these mechanisms involvement. However, I'm the only one that's really kind of put all this together. Like I said,
Yeah.
most practices, most clinics, they will bite down on one of the mechanisms and kind of just go with it. Whether it's dysautonomia or whether it's endothelial dysfunction, that will be their shtick for their entire basically career of their clinic.
Yeah.
They decided this is the mechanism and this is what they're going to do and this is the only thing they're going to do. That's what they're going to focus on. I treat all six of these.
It's actually very true. And I think it's why it's such a disjointed pathway for, even if you're in the public health, difficult to get any traction with treatments at all because nothing's been approved.
I can tell you, Alice, that what I see around here, and I get a lot of referrals from a lot of different clinics all around the country and even from Europe. I actually get quite a few referrals from Germany.
Okay.
But from here, a lot of clinics, they focus on physical rehab. Okay, physical therapy,
That's true.
physical rehab. This is not a disuse problem or kind of getting weak because you have long COVID. Okay, there's a fundamental issue going on with the mitochondria. And yes, exercise technically will increase the amount of mitochondria you have. Okay, no question there. The problem is when you already have mitochondrial damage to begin with, pushing it harder, doing graded exercise, things like that, will actually make things worse because it's like, think of it this way. You're in the desert and you're the overseer and you're seeing these mitochondria basically crawling on their hands and knees. They've been starved of food, they've been starved of water. They're exhausted. They're barely able to crawl a few steps. And you're standing there and you're basically whipping them to work harder. It's just not
Yeah.
going to work. I mean, they don't have anything
Yeah.
more to give. You got to fix the problem first before they're able to do what they're meant to do. And while I do think you do need to do physical therapy eventually, in the beginning, until you get your mitochondria fixed, it's really kind of a losing proposition. I don't like that approach.
Yeah. It's there was a couple of other studies I've seen that have basically with COVID, with long COVID, exercise or is actually harmful to the body because I guess the way you describe the analogy of mitochondria already struggling. So yeah, that all times what I've seen in other studies. What tests specifically do you do to diagnose it?
So let me lay it out here for you. There's really no biomarkers for long COVID. There really is not one. Now there are some that can be suggestive and things that we find often, but most of the time when you do labs, when you do imaging, for the most part, everything is going to be normal. And this is mostly frustrating for patients because a lot of their physicians will do the regular routine labs and everything comes back normal, and so they say, there's nothing wrong. I don't see anything wrong. They do the usual things they check,
Yeah.
and or it's very non-specific. There's some things that are positive or high, but they don't know what to make of it. So
Yeah,
I mean, I
confirm
can
that.
I can tell you some things that I do find and the kind of tests that I do look at, but it's not really to diagnose long COVID. It's really to diagnose or trying to figure out which mechanisms are involved. Um, I don't look at it as long COVID. I look as a collection of mechanisms that are damaged, and that's what we need to focus on to treat. So most of the time, I don't even need labs because I can figure out which mechanisms are involved just based on the triggers. So what do I mean by
Mm-hmm.
triggers? Okay, well, let's look at this. Dysautonomia, okay, which is a problem with your autonomic nervous system. Symptoms will get worse when you're standing. That's the POTS aspect, okay? Not everybody
Mm.
has POTS, but that's one of the triggers that will make things worse. Stress, physical, emotional stress will make fight or flight worse. Okay, a lot of the symptoms that you
Yeah.
see with fight or flight will get worse. A hot room or a hot environment will make dysautonomia worse. So if you have any or all of these, I'm kind of looking that dysautonomia is more involved. I
Mm.
mean, yes, you can do autonomic nervous system testing. Don't get me wrong. You can do a tilt test. You can do a lean test. There's a NASA lean test you can do.
Mm.
Again, but this is more for diagnosing POTS, not for diagnosing dysautonomia, right? There's certain ANS tests you can do. You can look at, so you can't measure ANS directly, autonomic nervous system directly. You have to look at what it does and how it responds to certain actions. So what do we look at?
Mm.
We look at heart rate, we look at blood pressure, and we look at sweat response. Those three things. So we do certain exercises, not exercises like aerobic. I mean just certain actions, and then we see how your autonomic nervous system responds. Okay, and from
Mm.
that we can determine if there is a problem or dysfunction in the ANS. But for the most part, there's no blood test you can do for ANS, and there's no imaging you can do for ANS. Um,
Yeah. Okay.
for mitochondrial dysfunction, I typically focus on lactate production and what's called an OAT test, organic acid test. Okay, and this looks at metabolites, not just mitochondrial, others as well, but it includes mitochondrial metabolites from the Krebs cycle. So this is a urine test, and
Yeah.
what I can glean from this is if there's a backup somewhere. So think of like a mitochondria working like an assembly line, and each part does their thing and sends off the product to the next part of the assembly line to work with. And
Yeah.
if one of those workers is not working well, or more than one, then things back up. So I can determine if there's a fatty acid metabolism problem, or if it's a carbohydrate metabolism problem, or if it's amino acid basically a problem. But then I can um, basically change or tweak my medications or supplements better to address the specific problem. And for gut, you can look at two things. One is you can look at the breath test, okay? And what I look for is um, both hydrogen production and methane production, okay? And there's two different kinds of breath tests that is
Yeah.
that you take in two different substances. Either one is fine. They each have their pluses and minuses, but this helps determine if you have SIBO, or a small intestine bowel overgrowth or bacteria overgrowth in your
Mm.
small intestine. And it's important to know that because you don't want to do just regular probiotics. If you have SIBO, you can make things worse. And you don't want to do
Okay.
prebiotics in those cases because you can make things worse. So it's important to know if you have SIBO going on or not. And again, I don't just pick a mechanism and say I'm going to test for it. I'm looking to see if there's actual problems going on with each of these
Yeah.
mechanisms first. For MCAS,
It's
I'm sorry, go ahead.
no. I was just going to say that actually, Gus. I'm very interested to hear that's one of the highest issues that we have, and I know that a lot of the kids in the long COVID kids group Facebook group that I'm part of, they have very similar, like a combination of symptoms. They all seem to have, the POTS, MCAS, and sleep issues, gut issues, testing.
Sure, and if you want to know a specific symptom, we can go over that how it works. But for MCAS, there's really no definitive tests. Okay, and it's also important to know that the MCAS that's associated with long COVID is different from the MCAS that you see that just happens outside of long COVID. Okay, it's not as severe. You don't see the anaphylactic episodes, or very little, compared to
Yeah.
the idiopathic ones that happen outside of long COVID. But nevertheless, there's no definitive test. Yes, you can check the histamine. Yes, you can check tyrus um, um, not tyrus. What is it? Tyrase. I'm blanking on one of the blood.
Okay. It's early.
Um, but my point is it's not definitive. Just even if it's negative, it doesn't mean that you don't have it. And
Yeah.
to me, that means that it's not really that useful.
Actually, it hearing you talk about something that's specific, being specific to long COVID. So it's making my, how long COVID is its own disease in its own right, because lots of people have talked about it just being normal post-viral fatigue syndrome or an ME. And I was always trying to define each when one crosses to the other, when long COVID becomes ME, or is it really ME? It's hard to
Sure. I mean,
define that.
I totally understand that, and they do share a lot of the same mechanisms and symptoms. Both ME, CFS, chronic fatigue syndrome, and long COVID. However, they're obviously caused by different things, different viruses. And I think that long COVID is its own distinct illness and disease, separate from chronic fatigue syndrome. And while even you can get a CFS-like condition within long COVID, it's still different from ME/CFS. Long COVID is a great masquerader. It can mimic a lot of other conditions, but it is a disease in its own right. It's its own distinct condition. And, if you think about ME/CFS, I mean, it's been around for what, close to more than 50 years, right?
Yeah.
There's been very little progress in terms of treatment for ME/CFS. So, on that standpoint, I prefer to look at long COVID as a separate condition anyway, because I think we're making a lot more progress with long COVID. And in fact, I think we're making progress for ME/CFS thanks to long
Yeah.
COVID. But I don't want to lump them into the same category.
Okay. Interesting. Yeah, because the ME group have definitely benefited, as I said, from the focus on long COVID, but it is, a very sad, debilitating condition, and it's a lot of the people in Europe have that combination of diagnosis. So,
and you can have both. You can have ME/CFS to begin with, that you've always had for the last, let's say, 20 years, and you could develop long COVID on top of it.
Right. Okay. And do you think it is the other way, that you have long COVID and you develop ME/CFS? The other way around.
I mean,
that works too.
Of course, the original cause of ME/CFS, which many believe to be Epstein-Barr virus. I mean, if you get it, I mean, there's no reason that you couldn't get long COVID and then ME/CFS after that. But it's more common to see the other way around.
Okay. Yeah, because I was wondering, obviously, because with the immune system dysregulation, or the poor performance of the immune system post COVID, long COVID, just equal to developing this additional viral, fatigue, ME.
Right. Well, we don't know what the I guess the risks for ME/CFS are, but I mean, we've identified a lot of the risks for long COVID.
Yeah, actually, I just read this morning. There's a decrease in the UK, and they found sort of, I'd like to use the correct wording, and I'm not a doctor, so forgive me, but 6 DNA strains that make you more susceptible to ME. It's genetic strains, yeah. So it was quite. Been doing a study for the last 5 years, I think it is. It's 15,000 people involved, so it was a very respectable amount of data, of criteria and data. Yeah. Sorry, I'm focusing on that because it's so hard as a non-medic to organize things in your brain, as a parent or a sufferer of long COVID, become just fixated on trying to find a resolution because you're so deaf. It's a horrible, debilitating, life-changing condition, and on different ends of the scale, you'd be debilitating because you're just more fatigued to the other end, where you're wheelchair bound, bed bound, can't eat, so severe. And I know that in the parents, that a lot of us have become kind of fake medics. We know we're not medically trained, but we feel like we've read so many studies that we could potentially have some input in what we're doing with our kids. So it's good to know that how you would define it, so we can be clearer going forwards.
Look, there's nothing is more painful than seeing your child suffer from anything, much less long COVID. To see their lives disintegrate, especially a young child. They're no longer able to interact with their friends. They're no longer able to be in school. I mean, there's just, I can't even imagine going through that as a parent. I have 2 children, and I mean, it's a debilitating disease. It is. It is a disability. I mean, there's no question. Some people are affected a lot more than others with long COVID. It's not a contest who has the worst long COVID. But what I do want to warn, despite the desperation, I mean, I just published an article on this, is not to use social media for crowdsourcing. And the main reason is because when social media is more about sensationalism, and things that work for some people get more attention than things that don't, even if it's the same thing. And correlation is not the same thing as causation. So if it's really, I had these symptoms and here's what I took, and I felt better, or I recovered, or I'm cured. I see these about a dozen times a week on various groups, on Facebook, on Reddit. I mean, you name it, it's there. The problem is since you're not addressing the mechanisms there, it's just basically like winning the lottery. I mean, you may have gotten some things right, or it may have just been placebo. You just temporarily got better for whatever reason. The problem is it's not translatable to somebody else, because I just told you that long COVID is a multi-mechanism disease, and there's different combinations of mechanisms working in each person. So the chances of getting the same result in another person are astronomically high that it will not happen. And it leads to disappointment. And meanwhile, you're spending a ton of money on all these concocted cures, and you're not really able to focus. So the biggest thing is yes, you're wasting money, fine. If you have a lot of money to spend, fine. I mean, but some people have very limited resources, and they spend thousands, if not tens of thousands of dollars on these. But you're also wasting time. So the longer you sit in this, the more difficult it is to treat. So
Okay.
you're not just wasting money, you're also wasting time. And that's kind of my beef with crowdsourcing on social media. I mean, I'm kind of reminded of that game. What is it called? Who Wants to Be a Millionaire or whatever, where you had a
Mhm.
lifeline and you can call a friend or you can poll the audience, right, for an answer.
Yeah.
But that has one definitive answer. Those kind of things,
Yeah.
okay? I mean, who was the president in this year? It's one answer. Long COVID
Yeah.
doesn't
Exactly.
work like that. It's multi-mechanism. It's just too complex uh, to basically get to the answer using crowdsourcing. That's my only point. And people get pulled down these false rabbit holes all the time. And again, like I said, it's wasting money, number one, and number two, you're wasting time. And time is something you can't get back.
It's completely true. I mean, I pre my daughter being so unwell, belief was that you get sick, and especially in Europe where you have health systems, national health systems, you get sick, you go to the doctor or you go to the hospital, they find out what's wrong, and then suddenly we're in this world of chronic illness, and then you do get into the internet and social media, and then you find these other conditions, fibromyalgia, etc., that have been around for decades, and have been ignored as well. And then the reason why I've, for example, with yourself, like followed you for a while is because I'm cautious, and I also stress that everyone out there should be cautious, because you know when you're desperate, you're very easily something that is offering you that golden chalice. So yeah, I agree, just not to get involved in those things and to try and have you know trusted recommendations
And
or
I've been warning
from them.
people about this for maybe the last 3 years. I didn't start with Facebook at the beginning. It never even occurred to me to even talk to people about long COVID, but I've been warning people about, desperation sometimes leads to silly decisions. And I
Mhm.
know, and I'm not blaming people for it. I understand it hurts to see your child hurt and suffer. And some people are themselves hurting and suffering. And I get the huge drive, huge impetus to want to get to the answer yesterday. But what I'm just trying to,
Yeah.
with this little gnat here is driving me crazy. um, what I'm just trying to say is you're not going. Yes, there's going to be one lotto winner. Yes, we see that all the time. Okay,
Mhm.
but how many people play the lotto,
Yeah,
right?
and do you know what? I have to say, we've had this with private. There are privates who significantly hike their prices or try and you into these unnecessary tests and what have you. So
Yes,
you know,
fair enough. And I've been called into question a bunch of times, and I'm trying to show you the evidence where I'm getting my information from, how I figured this out, why I'm doing what I'm doing. Yes, there are a lot of docs. I'm not going to mention any names. There's a few in particular that run certain panels that kind of go into the $700 to $1,500 range. I don't think it's very
mm,
helpful. I mean, sometimes my patients will send me these results, and I'm saying, well, that's great, but there's really no useful information for me to glean from this. I'm sorry that you had to do this, but it's not very useful to me. Um, a lot of functional docs, unfortunately, kind of go into the usual um, parasites, heavy
yeah,
metals, and molds. Now, granted, those things do happen, okay? But they're not causing long COVID. I mean, they existed long before long COVID, right?
Yeah.
And they'll exist long after long COVID. All your
Mm.
problems are not being caused by those three things. I wish they were, and it would be an easy fix, but they're not. So yes, a
Yeah.
lot of extra
Interesting.
tests. One of the big things that I see is the MTHFR genetic testing. It's pretty unnecessary, pretty much unnecessary. And the reason is MTHFR is not a clinically relevant condition.
Oh,
About
really? Okay.
It's not. It's not. A lot of people walk around there that are heterozygous with the MTHFR mutation. They live normal lives. They live normal lives before long COVID. They will live normal lives after long COVID. It's really not
Mm.
clinically relevant. Yes, you find something, and I know why it's exciting to find something wrong, because then you
Yeah.
could say, well, here's the reason why I feel sick. But
Yeah.
even if you have a homozygous mutation, it's really not making a huge impact on your life. Okay?
Yeah.
Methylation is important, don't get me wrong, but the MTHFR gene is not all that critical as people think it is. Um,
That's really interesting because that has been like a kind of a bit of a not a buzzword. That's the wrong word, but a commonly uh, used
right.
finding or mentioned
It's
finding.
exciting.
So
It's exciting. You
yeah.
finally found something, and now it's positive, and it looks like that is the reason.
Mm.
And this was propagated by functional med docs, unfortunately, as something to look into. But like I said, it really is non-issue. It's never been an issue. Um, if
Yeah.
uh, if you want to know what I find relevant, I can tell you. I look at CRP S, which is C-reactive protein high sensitivity (HS). If I see that positive along with increased interleukin 6, I know that there's inflammation going on inside your body. Okay, not
Mm.
everybody's going to see this positive, but it gets me to focus on different things if I see that's positive. So for me, when I when I order a test, it is for the purposes of changing what I'm doing. Okay, so I don't just order tests for the sake of ordering tests. I don't just look at a catalog of all the lab tests available and just order, thousands of dollars of tests. If I
Mm.
only order a test if it's going to change what I'm doing.
Okay.
Does that make sense?
Yeah, no, it does, and I had to just be and point out that fact because it is something that all of us communicate, together. We're all wondering who do we focus on because, there's like 4 or 5 doctors or clinics. There's 2 in the UK that are the only ones that offer a private long COVID treatment service, but one of them is completely profiteering from the situation, and the other is lovely and doing great work. Um, there's clinics, the clinic in Cyprus, that's running, it's expensive, etc. There's clinics in America that offer a kind of a vagus nerve reset of approach to quality of life, and yeah, it's just hard to know where to focus and who to trust.
Well, I'm
So
going to
thank
tell you where
you.
to focus. You're going to focus on the 6 mechanisms that I mentioned. So
Yeah.
everything that should be done diagnostically should be focused on determining which of the 6 mechanisms you have, which combination of the 6 mechanisms you have. I
Mm.
mean, we didn't quite finish kind of going through all the mechanisms and the tests
Oh,
that
sorry,
I look for.
I
But
apologize.
but but my point is if I don't suspect endothelial dysfunction, I'm not going to be testing you for endothelial dysfunction. If I don't suspect histamine, I'm not going to be testing you for histamine intolerance. it's not just ordering tests willy-nilly, just for the sake of ordering. And I get kind of beat up sometimes for it. Well, you must not know what you're doing if you're not ordering thousands of tests like Dr. So-and-so. Well, I
Yeah.
mean, so some people equate the number of tests you order to how good of a doctor you are. The more tests you offer, you order, the better doctor you are. Did you know that?
Mm.
Um, yeah.
Yeah.
So if I order thousands of tests, I must be a better doctor. People don't look at it like, well, maybe this guy's actually critically looking at what needs to be ordered and what doesn't, not just ordering a whole catalog of tests. So
That's actually,
treatment,
I was going to,
go ahead.
you were going to,
What I was going to say is, treatment is guided by each of these tests. So
mm,
if I don't think a test is going to make a difference, then why am I ordering it?
it's actually, it's when you mentioned you reiterate that the backbone of this is focused on those six specific areas. And it's leading me into the question of, the help apheresis, or however you would like to pronounce it, which has been really sort of growing very much so in Germany. There are a couple of other clinics, but it's very much a focus in Germany, and a lot of people are for treatment, and hailing it as a very significant part of the treatment for long COVID. Now, Isla's had it. She's
Yes. And that's the help apheresis, just to be clear.
It is, yeah. And it's absolutely changed her. There are still issues, so it makes me see that your mythology is correct, because we haven't focused on all areas yet. Obviously, it was a significant part of her problem and has helped her enormously to get rid of the spike protein. She has a lot of clotting issues. That's very much the focused on theory, I would say,
and
here.
let's talk about help apheresis. So first off, help apheresis was created to remove lipoprotein, okay, which is a part of cholesterol. It's approved for removing a certain type of LPA, which is lipoprotein that can accumulate in certain conditions. We're not talking about long COVID here. It does have a secondary effect of removing fibrinogen, which is one of the clotting proteins. Now we have a whole cascade of clotting proteins, and in some people with long COVID, they accumulate excess fibrinogen, and there's various other mechanisms involved that basically form complexes of fibrinogen and amyloid protein, which colloquially has been termed microclots. Okay, now help apheresis it does remove fibrinogen. It removes some of the cytokines as well. But really, the main mechanism and the primary function of help is to remove fibrinogen, okay, in long COVID.
Okay.
It unfortunately does not remove spike proteins. It does not remove really autoantibodies much. It does some, okay? It does remove some cytokines. It does remove some autoantibodies. But if you wanted to remove cytokines and antibodies, I would choose plasmapheresis over HELP.
Okay.
It's a different filtration technology, and it targets different areas in your blood. The reason why I say it doesn't really touch spike protein is because I don't believe the spike proteins to be circulating around in your blood. When a spike protein is found in your system, it will contact an ACE2 receptor on any cell. I mean, obviously, a lot of it is going to be in the immune cells, but It can really do this pretty much in any cell in the body. And the whole complex is going to be taken inside the cell. It's going to be intracellular, okay, inside the cell. Inside the cell, it's protected, okay? Kind of like malaria is protected inside the cell, or Lyme disease is protected inside the cell. Antibiotics can't touch it. Plasmapheresis can't touch it. Help apheresis can't touch it. It's inside the cell. It can only touch anything that's outside floating around your blood, which is where you have antibodies, for instance, but not spike protein. Okay, so
would you
go ahead.
Would you have a? I'm guessing not, because sense tells me that you can't, destroy a cell, destroy protein within a cell. But is treatment for that, or any?
Funny you should mention that. I'm actually working on a paper to explain a proposed mechanism of getting to the spike protein inside the cell. Okay, there's two things I'm looking at that potentially can help. Now, this is all theoretical. It hasn't been shown to help for spike protein in particular yet. But based on the way I worked it out, it should, in my opinion, help. However, since we are talking about spike protein, I'm going to tell you that the spike detoxes do not work on removing the spike protein for the same reason I just told you that help apheresis doesn't help with spike protein, and that is because it's intracellular. It's inside your cells. It's protected. For better or for worse, they're protected. So, I mean, taking nattokinase, taking curcumin and bromelain, those are all nice things. They have antioxidant properties to them, but they're not touching the spike protein. Let's be real here. They're helping with endothelial problems or microclots. Nattokinase can technically break apart clots, including microclots, but they're not touching the spike protein because they don't really have access to the spike protein. So why your daughter got better is because that was one of her mechanisms. Endothelial dysfunction causes microclots, it causes accumulation of fibrinogen, and help apheresis reduces the fibrinogen. But like I told you, it's a third most common mechanism. And really what you need to do with your daughter is to determine which of the other 6 mechanisms she has. And I told you, for the most part, most people with long COVID, whether it's children, adults, or elderly, they're going to have more than one mechanism involved at the same time. And these mechanisms collaborate against you, unfortunately. One may be the primary, let's say like dysautonomia, but the mitochondrial dysfunction makes the symptoms worse on top of it. So, and the same thing goes for the other way around. There could be a mitochondrial mechanism and the dysautonomia is making the symptoms worse. So, I mean, it's very unlikely. It's not impossible. Nothing in medicine is 100%, never or always. But it's just uncommon to see just one mechanism involved. So it's possible to have endothelial dysfunction as the main mechanism, but there's going to be usually underlying mechanisms under that.
Yeah, no, seeing your chart, there's definitely, I would say probably at least four of those relevant to my daughter specifically. Actually, I had organ questions I was going to ask you. And as I looked down, I looked down the list and I realised that either some of them are not relevant now or you've answered them already. But talking about the from a parent's perspective, I've tried to make this relevant to a wider audience, not just parent focused. But one of the questions put around is, or the uncertainties is, with the brain fog, with the lack of concentration, with the kind of anxiety that we see with our children, what exactly is causing that, and is it going to be going forwards?
Sure. Yes. all of this is fixable. All of this is possible to go into remission. How do I know this? Because I've done it. I've done it over and over again with multiple patients, including children. I mean, I've gone, we've treated kids. I've treated a child who came in a wheelchair and he walked out. I've treated children who have not been able to go to school and they're back in school and basically participating in their usual activities and um, usual clubs, and their energy has increased. And so let's kind of look at what's going on. So anxiety is primarily a dysautonomia, fight or flight symptom. Yes, the other mechanisms can contribute for sure. Okay. But if you now have anxiety and you haven't had anxiety before, the child wasn't anxious before, this tells you it's going to be fight or flight. So fight or flight is a survival mechanism. Okay. It's a very primitive mechanism. Every single organism that's multicellular has this. Everything from humans to mammals to every single animal, including bugs. And you know this in a bug. If you ever brushed up against a bug and it runs away, that's the fight or flight. It's meant for survival. It's meant for occasional use for surviving, not being in your body active 24/7. So if you have fight or flight that's activated, and this is primarily due to long COVID, because it damages your autonomic nervous system. It's a sympathetic mechanism. Your sympathetic system is working overtime. Your sleep will be affected, which means you won't get deep sleep, which adds to the anxiety because you're not able to recover from the night before, from the day before. So it's about treating the dysautonomia, okay? And the way I do this is with vagus nerve stimulation and not the woo-woo type of vagus nerve stimulation, but directly stimulating the vagus nerve at the ear. Now, you can stimulate it at the neck if you want, but the problem with neck is you're limited to only a few minutes. You can't really stimulate the neck for more than a few minutes because of the side effects. It's going to lower your heart rate. It's going to cause gastrointestinal problems. You really can't stimulate it at the neck for more than a few minutes. That's why I choose the ear. It's more gentle, and you can stimulate for 30 minutes or 60 minutes, and it's not usually going to cause problems. Stellate ganglion procedure. Okay, stellate ganglion block procedure. And that works mainly on the sympathetic side by breaking the sympathetic overactivity loop. And that has downstream effects.
Is it a dangerous procedure? In my naivety, I don't know what you do.
It's a complicated or advanced procedure, but in the right hands, it's very safe. I mean, I've done close to 5,000 of them safely. So it really kind of depends on who's doing it. I prefer ultrasound guided, but look, it's like, I kind of liken it, people think that all doctors do things the same and have the same skill sets, and that's fine. I say, well, let's look at Indy 500. The drivers there are all experienced, right? Nobody's doing their very first drive in the Indy 500, right? They all are experienced drivers. They know how to work the car really well, but you have one winner. Why is that? Why doesn't everybody cross the finish line at the same time? They all are experienced drivers. They all are very good drivers. They know how to drive the Indy 500 cars. But why don't all of them cross that finish line at the same time? Why is it easier to see the difference there than to see a difference with doctors?
I mean, that's been another one of the minefields as a general member of the public, just trying to just really to see who knows what they're doing, and every doctor has a different opinion because they're human. They have
I know.
there's,
And there's a joke in medical school. What do you call the doctor, or the medical student that graduated with the worst grades?
don't know.
Doctor. Doctor. Doesn't matter. I mean,
Yeah,
the bottom line is they're still a doctor. They still get an MD or DO,
yeah.
and they're going to go out there and practice. And you're going to be the one that sees them.
Yeah.
You're not going
Actually,
to know that they graduated the last in their class.
can I ask, actually, what made you turn to focusing on long COVID?
That's a great question. So when I was, going back to 2019, 2020, I was performing the stellar ganglion block for PTSD, for vets, for people suffering with PTSD. And we started seeing patients coming in with loss of taste and smell, or abnormal taste and smell.
Okay.
And they just happen to have PTSD too.
Yeah.
And their symptoms got better. Their taste and smell resolved, and that made me curious. And this was
Yeah.
before long COVID was a thing or even had a name. Um, and I started trying to figure out what this was. And I guess towards the middle of 2021, long haul and long COVID became a thing, or it got a name. And I was researching more and more into what was going on, and we kind of figured that it was probably similar to MECFS, which is what you were hearing out there. You
Yeah.
started seeing more symptoms manifest besides just taste and smell, like the brain fog, like the fatigue, like the anxiety. And I started looking to see what else was going on. And initially, I just focused on dysautonomia as a primary and only mechanism. I started to include mitochondrial dysfunction when more and more evidence was coming out showing mitochondrial dysfunction. Then I added gut and MCAS and histamine excess, and then the other mechanisms. Basically, as more data was coming out to show, so I kind of dove down into this. I took a particular interest in long COVID. It
Yeah.
piqued my curiosity and interest, and I wanted to get to the bottom of it. And I've been digging at it ever since for the last 5 years. Um,
Yeah, I know we spoke
Go ahead.
before we started this, and I know you have a very long
No,
and
it's
you
okay.
dedicate yourself.
I have plenty of time. I budgeted a lot of time for you. So, I mean, this is kind of how I got into this. I mean, I started off with, with this. Now it's my second edition, but this basically breaks down all the mechanisms, nice and thick, the complete long COVID handbook. And then I decided that I was going to make it into a multi-volume set. And I wrote this one, which is for the dysautonomia, which is kind of the biggest mechanism, right? And then I wrote the third one, which is the mitochondrial dysfunction one, right? And I'm about to release volume 4, 5, and 6. And since I was already working on the hormone stuff, I ended up releasing the volume 7 a little bit early, but I was kind of done with it. So I figured, let me go ahead and release this early. I'm also coming out with a mechanism-based way of looking at each of the symptoms. So basically, each symptom is broken down into its mechanisms. And each symptom will show what is the primary mechanism, but also what are the secondary and tertiary ones that are driving the mechanism, to kind of help determine what is going on. But I still think focusing on the triggers first is the right way to do it.
Actually, I was hoping that you would share with me your
So what diagram?
the different The one with which the different areas. I'm sorry. Dysautonomia, MCAS, etc.
You mean the one that I put up in the beginning?
Yes, exactly.
I mean, I could send it to you. It's like I said, I just put it together real quick just before the podcast we're doing now. I basically just put this together 15 minutes before. I mean, it's fine. I can send
Yeah,
it
no,
to you.
because I think parents we very much appreciate a nice, simple structure to something that we can to go through, focusing on recoveries. I was. Can I ask you? Did you hear a ping come through? Is a noise coming through to you?
Yeah, I hear it. I'm not sure where it's coming from. So I just wanted to kind of go back. You asked me about anxiety, which I told you about, but brain fog is a collection of what we call executive functions. Okay, so things like memory, short-term and long-term memory, concentration, um, and basically ability to make decisions and switch from one activity to another is all part of um, what's dysfunctional in brain fog. And
Yeah.
the main culprit for this is mitochondrial dysfunction. Okay, and the mitochondrial dysfunction causes the neuroinflammation, which causes the brain fog. Now, other mechanisms are also involved. Okay, dysautonomia can contribute to this by altering blood flow, as an example. Endothelial dysfunction and clots can cause microvessel disease, basically reducing the oxygen supply to certain areas of the brain. Gut can cause a problem from the LPS. If you're
Mm.
if you're producing lipopolysaccharides from your gut, and that could be just from your own flora, mind you, not even pathological species. But this comes from the cell wall of gram-negative bacteria, okay, that live in your gut, and this is particularly toxic to the brain, okay. Um, MCAS histamine, again, there's an H3 receptor. Now, we're familiar with H1, H2. H1,
Yeah.
right? H1 uh, causes issues with allergies that we see, right? Like runny nose, red, watery, itchy eyes,
Yeah.
that kind of stuff, runny nose. But H2 are causing issues with the gut, right? Mostly the gut, like
Mm.
acid reflux and acid production. But there's also an H3 and H4 receptors that we don't have specific antihistamines for, but H3 also works in the brain
Okay.
and can contribute to brain fog that way. And hormone imbalance, the big ones there are estrogen, okay, and progesterone. Those two plus thyroid hormone. If you have deficiency in any of these, and of course, in a child, you're not going to necessarily mess with estrogen or progesterone
Mm.
too much unless they're um, post puberty already. Uh,
Yeah.
but a young child, you wouldn't necessarily be messing with it, but you may help with thyroid, for instance. But all of these can contribute to the brain fog originating from the mitochondrial problem.
It's fascinating because you're the only person too that has an overview of all areas. Like you say, people focus on one specific
Yes,
mechanism.
because it's easy to do. It's easy and very profitable to basically latch on to one thing and just push that one thing, whatever that is, whether it's a dysautonomia or endothelial dysfunction or whatever. Um, that's the mechanism, and that's what I'm going to focus on, and that's all I'm going to do. But look, I told you, I have people reaching out. I have patients reaching out from all over the world. I have a lot from the U.S., but I have a lot from Europe too. I have from Germany and from the UK and from Netherlands and from Norway and from Australia. I mean, if we had a few from France. I mean, pretty much any country except the Middle East for some reason, or Israel. I haven't gotten anybody from,
Mm.
and I haven't seen anybody from Russia. Um, but
I'm guessing a great relationship between.
And shockingly, I haven't seen anybody from North Korea or Cuba. I don't know. Just haven't had any takers from there. But pretty much from everywhere else you can name, any country, even small ones. I've seen somebody from Guam. Um, Basically, pretty much anywhere else, people reach out to me for help. And if nothing else, I do telemedicine or televisits from around the country. And I even do them in 240 languages. We have a live translator that will translate pretty much any dialect, any language you can think of or exists. I won't do Klingon, okay? But or Pig Latin, but pretty much any other language is fair game. And the
Yeah.
point is I can get you in the right direction. I can structure the plan for you, even if you can't come and see me in person.
Yeah.
What I can do is I can set up um, a plan for you. Basically, here's what you need to do at home. Here's what you need to ask your doctors to do. Now, of course, some doctors may not want to cooperate or collaborate, and that does happen. But I could at least get you to think about long COVID the way I think about it. So even though it's a very complex condition and illness, if you break it down into its components, it is very manageable, and you can treat each one of these. Now, some of the mechanism can take 6 months or a year or even longer to treat, but you will get
Okay.
better. Okay, 90% or more of my patients get better. Okay, they're not cured, but they
Yeah.
get better. I get them into remission. I get their quality of life better. I get them back to work. I get them back to school. I get them back to college. I get them back to their activities. That's the whole point of this. Okay.
So,
Otherwise, why do it?
well, it's amazing. That's a fantastic. And actually, I just want to be realistic about this because we did, again, talk before we went live that you this is a chronic condition.
Yes.
And
Yes.
treatments will improve quality of life, but as of yet, an actual definitive cure is not available. It is about making those mechanisms better. And there's a question that everyone always asks, that's terrified about COVID, because we have people in the group who will still wear masks. People who don't but are terrified and avoid big crowds, etc. And really, it's quite a depressing way to live, and it's very hard with children because you don't want to mentally, damage them even further by creating issues. So, when you get, is there something you can do? Do you have an idea of a protocol for a long COVID sufferer? You've got a bit better, and then you catch COVID. Should you do?
So there's kind of mixed data on somebody who suffers long COVID already, what to do next. Okay, so there's mixed information coming out about getting COVID again. So if you're at risk for long COVID and you have long COVID, you're always going to be at risk for long COVID. Okay, so
Yeah.
whatever risk factors you have still exist. Whether you catch long COVID or not, whether you get COVID again or not. There's been some reports of some people getting better after catching another virus or COVID again. Those are usually temporary. You won't hear back from them saying, my symptoms came back. So the story usually is they get sick with something else, and either all their symptoms resolve or they get significantly better. The thing that you don't hear is that their symptoms came back. And again, that's just how social media works. You're more likely to hear about the positive rather than the negative stuff.
Yeah.
It's usually a temporary break in symptoms, and there's a mechanism behind it, but in general, you don't want to get sick again with COVID. Okay, don't make that a priority or something that you're looking forward to in an attempt to get better, because getting sick
Yeah.
again will cause more damage. The same issue, the same problems that occurred the first time will likely happen again. So, I mean, look, I usually recommend common sense things. Okay, and I know we didn't mention the COVID vaccines and stuff, and it's up to you if you want
Mhm.
to go there or not. But um, if you're in a very crowded indoor area, yeah, I would mask. If you can avoid crowded indoor venues, then avoid them altogether, especially if
Mm.
you're at risk for long COVID to begin with. Like I said, just common sense stuff. I mean, there's no hard and fast answers to this, but if you're outside, you're less likely to be um, subjected to COVID. Even if somebody is sick and they're not really all that symptomatic.
Mm.
And some remember it incubates. It could still be infectious before the person shows symptoms.
Yeah.
So, but you're less likely to get it outdoors than you are indoors. I mean, if you're having a huge convention or a huge meeting or a large family gathering with a lot of people, wear a mask. Wear a mask. Is it going to be 100% surefire way to prevent um, COVID? No, of course not. Even if it's an N95, you can try using some of the barrier methods. There's some nasal sprays that
Mm.
that are available in different parts of the world, depending where you are. There's one in Israel. There's one in Europe. There's a few in the U.S. One uses xylitol, for instance, as a type of barrier. But these are not, again, 100%. There's no 100% effective method unless you kind of live in a cave somewhere in the woods without any contact with human life. That's really the only
Exactly.
100% sure way to prevent COVID infections. COVID is part of our landscape, part of our lives. Unfortunately, it is. Once you let this thing out of Pandora's box, it's out, and there's no way to put it back in. So COVID is going to be part of our landscape for the rest of our lives and basically for the rest of humanity. If you look at flu, the very first flu case, it was very deadly. I mean, it killed off about a quarter of the U.S. population, of the world population, I should say,
Okay.
approximately. So it was very deadly. But in the future, as it evolved, as it changed, um, it wasn't as deadly. And kind of, we're seeing the same thing with COVID. I mean, the initial variants, the original alpha, original COVID strain was very deadly. Alpha was deadly, Delta was deadly, but this Omicron one is not as deadly. I mean, we're not really seeing a lot of hospitalizations for it. So the long COVID risk has decreased as well.
Okay.
Initially, it was around 10 to 30%.
Yeah.
So from the alpha and the delta, but if you go to the Omicron ones, we're in about 6 to 7% range for non-vaccinated or unvaccinated people, and 3 to 4% for vaccinated. Now, why do I mention that? Because the COVID vaccine, as much as I have my problems with it, um, does reduce the risk of long COVID by 50%. Now, this,
Right.
of course, doesn't look at the COVID vaccine injury or COVID vaccine injured. And certain
Mm.
certain people who are susceptible are going to develop a condition very similar to long COVID, which
Yeah.
stinks, which stinks because you're trying to avoid the problems from COVID, and you develop something brand new that basically mimics the same problems that you were trying to avoid. So I'm not here to recommend or tell you to get vaccinated. I'm just presenting the facts. These are data points, and
Yeah, it's a
are out there.
personal choice.
What other questions do you have for me, Alice?
Well, I literally could talk to you for probably going into
Well,
depth.
let's stop at around 9:30, and then I'm going to just address any questions that are in the chat,
You know,
and
I agree.
we'll conclude there.
I agree because I think when you're too long, obviously people
Agreed.
who watch
People
this,
with brain fog and fatigue can't
yeah,
really tolerate a super long feed.
exactly. But I will share with the groups that I'm part of, the your websites if they want to get in touch with you. I'm presuming that's okay with you.
Yeah, of course. I mean, my website is free for everyone. I also run a kind of a paid community group. It's called Long COVID Family. .com, and it's just for people who want to have more access to me. So while I am active in Facebook, I typically don't answer a lot of questions in my group, but in this community I do, and
Yeah.
it's just a way for people to get more access to me if they want it.
Yeah, and actually I do want to say again, we all have to be realistic in that you're still doing a job, you're working, you need to earn your living, and to you give your time, you give a lot of your time without asking. So I can understand why you wouldn't in those Facebook groups answer questions, because you'll just end up down a rabbit hole where you're
To be
answering
fair, I
millions of
did answer questions there for 2.5 years.
yeah,
With no time constraints. I would do this 7 days a week.
yeah,
Morning till evening, sometimes into the wee areas of the night, because I guess some people from Europe would be, obviously a time difference. But I decided to focus my time more on the community. Uh, and for people who really want to hear my opinion, not just argue or complain about something. I mean, I have my share of critics, just like anybody who's in the public light, I guess. Um, but I hope I have explained why I do what I do. One thing I do that really nobody else does for dysautonomia outside of Japan is offer the EAT procedure, which is the epipharyngeal abrasive therapy, and that focuses more on the vagus nerve, on the glossopharyngeal nerve, and the trigeminal nerve,
mm,
which is three of the cranial nerves that are damaged sometimes in due to COVID.
okay,
And it also helps
yeah,
clear out some of the remnants that are stuck in the back of your throat. And I've seen a lot of success with this.
yeah. I've heard about reservoirs of another doctor I've met along the way mentioned reservoirs of the virus staying in certain areas of the body, like the gun.
One thing I
Yeah, I
see
don't
is IgA. People have low IgA, and that's one way to correct that is by working on the EAT procedure. But anyway, that's neither here nor there. But do
yeah.
you have any other questions for me? Otherwise, I'm going to go to the chat and we'll go through what questions we see on chat.
No, I have nothing further for today. It would be
Okay.
going on for yeah.
So, um, so let's kind of take a look and see what questions we have out there. Hang on, let me make this a little bigger. This is from Sim. Do you have any plans of expanding treatment or training EAT to providers in UK? Yes, I do. I just haven't created the mechanism or the plans yet how to do this. Another question from Sim. Yes, I do offer telemed to anyone in the world who has access to the internet. I mean, if you're able to get online, you should be able to reach me. And like I said, we offer 240 languages and dialects. live. This is not AI. This is an actual live person that will be translating.
Oh wow!
Yeah, if you're,
Really?
yeah, absolutely. If you're interested in doing that, you can contact me on covidinstitute.org. Just request an appointment under international, and we'll get you taken care of. Let's see here. Where Sosima, okay. Not really a question, okay, just a comment. Um, and the last one here is from Dana. What if we can't be sure if COVID is the root cause? Symptoms started after a mystery illness, March 2020, but didn't seem like COVID. So, COVID tests, even the ones done by labs, are not 100% effective. So, each of the tests will have a sensitivity and a specificity. Okay. And none of them are going to be 100%. If things look like long COVID, it probably is going to be long COVID. Of course, we've been talking about long COVID, long COVID, long COVID, but of course, there's other conditions like chronic fatigue syndrome, like Lyme disease, like many other medical conditions that are out there that can still occur and exist together with long COVID or just separately. So, yeah, that goes into the diagnostic process. Is trying to figure out, but chances are, if you think it's long COVID, most likely it's going to be. Um, it is very prevalent out there, and a lot of the mechanisms that I mentioned also apply to chronic fatigue syndrome. Okay, even though it's a distinct process on its own and has a different way of manifesting. But I think a lot of the things that I worked out for long COVID is also applicable to chronic fatigue syndrome. And guess what? I treat a lot of patients with dysautonomia. I treat a lot of patients with ME/CFS. And because a lot of these things are applicable to these conditions as well. So, and I treat POTS. So I hope that answers your question. That's it for the comments. And Alice, if there's any last words you want to add before we close up?
Oh, I just want to make my thanks. I really appreciate clarity in terms of what are the mechanisms and how it's the big picture overview rather than just this narrow focus on one thing. How important it is to look at the big picture. So I really appreciate
it. It really is. Like I said, long COVID is a very complicated condition, complicated disease. And if you lock yourself into one of these mechanisms and say, well, this is the cause, and this is what I think is causing everything, and that's all I'm going to treat, you're really limiting yourself, because it does involve multiple mechanisms most of the time. And unless you address most or all of the mechanisms, you're not going to get to that remission point. People have accused me of being or sounding very confident, and accused me of a lot of other things. But look, I've never claimed a cure. I've never said I know how to cure long COVID. I said that I get you into recovery or remission. I don't know for how long, because we don't know the full scope or extent of long COVID. We don't know if it's going to turn into basically another CFS ME type condition or not. But it is chronic. I mean, it's been around for at least 5 years. But the way I approach it is why I'm confident about it. All of the mechanisms that contribute to and cause long COVID, and because these are the root causes of long COVID, I found this from experience, this from treating it for the last 5 years, is by treating these root causes is how we get long COVID to regress and basically go into remission. Like I said, I'm not promising cures here. I'm just looking at this as a way to improve your quality of life so you can get back to doing what you're doing, as opposed to wasting time and money on spinning your wheels with long COVID.
Yeah. 5 years trying to determine what is going on. So it's nice to get to this with a bit of clarity. So thank you, and I will be in touch with you to get the specifics that I can send, the links I can send to people for various bits and bobs. So again,
Sure, I'll send you that thing I put together, the 6 mechanisms, and like I said, I'm just trying to finish out these books to address each of the mechanisms separately.
Super. Right. Well, I wish you a good day. It's early for you. It's getting late for me over here in Germany.
This is nothing. I got a full day ahead of me.
Oh wow. Okay. Thank you. Yeah. We will be in touch, and maybe we'll of these on something.
I'll be happy to do more for you, or if you want to focus specifically on pediatrics or children, we can do that. However you want to do it is fine with me. I mean, I treat children too. But yeah.
Thank you, Dr. Groysman.
All right, you're welcome. Hang out for a second here. I'm going to close up the stream. Take it easy, everybody.